Good afternoon once again, everyone, and welcome to this session on designing for the real world, how to test and scale interventions in public system. So in this session, Miri Muntean will share insights on practical strategies for developing, testing, and scaling solutions that work within the complexity of real-world public systems. She will also show how to design interventions that are not only innovative, but also adaptable, data-informed, and context-sensitive. A bit about our speaker. Miri Muntean is the co-founder of the Access to Medicine initiative. She works to improve access to contraceptives by strengthening public health supply chains in Nigeria. With a background in project management, research, and global health, Miri leads direct implementation and policy engagement efforts focused on reducing stockouts in the public health system. She previously worked with charity, entrepreneurship, and family empowerment media, as well as for a private e-learning agency. Kindly note there will be Q&A session after the talk, so feel free to send your question via swap card. Ladies and gentlemen, please join me in welcoming Miri Muntean.
Thank you. Thank you very much, everyone, for giving me the opportunity to speak. I would like to tell you a bit about how we decided on how to run our intervention, and in doing so, hopefully give you a few tips that you can use if you're thinking about starting your own organization or your own project. But if there is only one thing that you take away from this talk, I want you to know that I don't think there is a right single answer to doing anything, and that the way to design an intervention and the way to find what works best is to be very sensitive to the context that you are running it into, and to try to gather as much data as possible and to try to test your intervention as much as possible. So I think most of you probably know that maternal health is a very big problem in Nigeria. It is estimated that 11,000 lives could be saved annually in Nigeria by meeting all needs for contraception, just in terms of maternal mortality alone. And 60% of women in Nigeria have an unmet need for contraceptives, with 29% of pregnancies being unintended. Now, we started by looking at this problem by trying to understand how we can increase access to contraceptives. And there are a lot of different things that one can do. There are a lot of interventions that are already being run. There are a lot of interventions that are run, for example, in creating awareness and giving information, such as the wonderful family empowerment media who gave a talk yesterday. And we also keep hearing that one of the big problems is not just access to information and not just that there are other cultural or religious barriers, but also that contraceptives are simply not available. So we started out to work on that. And we wanted to first validate whether that is true in the Nigerian context. We wanted to make sure that just providing additional commodities in public health facilities would be sufficient to lead to uptake in the absence of any other interventions. In other words, we had a problem that we wanted to solve, and we thought it was important, and we thought it would be impactful. But before starting out to design the intervention, before spending a lot of time in running this intervention, we wanted to validate that solving this problem would actually be impactful, and it would actually lead to the results that we wanted to find. So in this case, for us, it looked like trying to gather data on why women who go to public health facilities for a family planning consultation, so women who already have a need and already want to meet their need by accessing modern contraceptives, why did they go through all the trouble of going to public health facilities and then left without taking a method? So in doing so, we designed a register that we wanted to make as quickly as possible to fill out for health workers in public health facilities. where we asked them to just tick a box for the reason on why someone leaves without a method. Not capturing any additional details for the patient. We didn't tell them what we were looking for. We just wanted to make sure that there are enough women that are currently having the exact problem we're trying to solve, going to public health facilities, asking for family planning, and leaving because they're not available. So the results we had showed that about 70% of the women who leave empty-handed, despite going to health facilities, did so because of stockouts. There are, of course, a couple of other reasons why some women did seek out this consultation but didn't take up a method that aren't going to be directly addressed by our intervention. For example, positive pregnancy test. That means that woman just cannot access contraceptives because she's already pregnant. But some of them need to consult their husband. Some of them are afraid of side effects. That is not something our intervention would solve. However, we saw about 11,000 women over the few months where we ran this program in a couple of LGAs in Sokoto and Katsina states, who we could help with this exact problem. And knowing that we have a problem we're solving, we then set about trying to come up with an intervention. So some of our colleagues at Charity Entrepreneurship start out with a very clearly defined intervention. There is this one program that has been run successfully, that has a lot of studies behind it, and just go and replicate that in new areas. For us, we started from a problem that we saw that we wanted to solve. And in coming up with an intervention, we first did a lot of research online. We read a lot of scientific papers. We read a lot of blogs and websites of organizations that are working in the field to try to understand what are other organizations doing and what is currently being done and what has been successful or not so successful in ensuring the availability of contraceptives, but also other medicines in the last mile. And what we saw is that a lot of different things have worked in some contexts, but not in other contexts. So we needed more information that we couldn't really get just by doing desk research. So our next step was to contact experts, some of them working in the NGOs we had read about, some of them just people in the field, and some of them I just went to northern Nigeria, visited a couple of health facilities, talked to the health workers in the health facilities to understand what their problems are and how they think they could be solved, and talking to a couple of the patients and understanding how they could be solved. For your program, maybe you won't have to go through all of these steps, but I do recommend getting a sense of what is out there and what other organizations have already done successfully or not so successfully before putting a lot of efforts into one particular intervention. So what we found is that there are a couple of different angles to approach this problem from. One of them is that there isn't very accurate data in the public health system in Nigeria on exactly how many commodities are needed where. Currently, this is estimated based on previous consumption. The problem with estimating the need based on previous consumption in areas where availability is very, very low is that if everything gets consumed, that doesn't actually tell you anything about how much would have been consumed, how high would the need have been if commodities would have been available. So that was the first problem we wanted to find ways to solve. The second thing is, in order to do that, we decided we will just procure a lot of commodities, and we picked about 32 health facilities that we wanted to supply with enough contraceptives and other commodities such as gloves or disinfectant or plasters, everything they needed to insert those contraceptives safely. We wanted to provide them with enough commodities to tide them over for the 2-month period between re-deliveries from the state government, and measure how high is consumption actually if stockouts are not a problem and if consumption is not limited by low availability. And of course, in order for this to work, we needed to find ways to deliver the commodities on time to every single health facility. In our pilot project, we found it was very important to work with every single clinic that is providing family planning services, because it was very important for us to solve the problem for as many people as possible. If we would have wanted for our program to be run easier, the easiest thing to do would have been to just work with the general hospitals, which tend to be much better connected. They tend to be in urban spaces where they're very easy to reach. But also, they are usually the ones that are already best supplied exactly because it's easier to reach them. So if we would have only focused on that, we would have unfortunately left out a lot of women. Going in, our expectation was that we had been told that there are a lot of commodities in the system and that they are just not distributed well, and that we need enough data to redistribute them and to make sure that we fix the distribution channels, and that would be enough. And I'm very glad that we didn't only work on that we also procured additional commodities and put them in facilities. We weren't doing that because we thought there was going to be an intervention we would run later. We were doing that to measure the impact of our intervention. But in doing so, we realized that the interventions we thought and we had been told would be impactful, such as getting good data and making sure that the delivery systems are well funded and run on time, would not have actually solved the problem. However, in the facilities in which we donated additional commodities, we saw consumption increase significantly. The lowest increase was for injectables. There was a 30% increase in injectable consumption. There was a 75% increase in pills consumption, a 90% increase in implant consumption, and a 240% increase in condoms consumption. Now, some of the methods are not displayed here. For example, IUDs are a commodity that is very often favored by a lot of different programs. The reason why IUDs are favored by a lot of different programs is because they are very cheap and they are very, very cost effective. They offer up to 10 years of protection for very little, for a very small sum, often under $1. However, what we saw in our pilot is that a lot of women don't actually want to use IUDs, and that if we were to have gone with what other organizations thought is important, we might have ended up with a program that would have possibly been cost effective, but would not have served the most possible women. So with these learnings, our next steps are going to be validating that what we found, that the single most important thing we can do is increase the number of contraceptives in the system, regardless of how they're distributed and regardless of the data system. And we plan to do so by direct delivery. We plan to cover an entire state for a year. We already have pilot results that show if you give commodities to facilities, that's good, and a lot of women will consume them. The problem with that study is that it has been done over only a few months. And of course, if something is not available for a very long time, the moment it comes in stock, there is going to be a massive spike in consumption. So we don't see our intervention as having been validated and something that we are ready to run and keep scaling up. But what we see is we have validated it is worth working on. And our next step is to gather even more evidence. In this case, ensuring that the demand is indeed much higher, somewhat higher than is currently assumed in the health system. And that even if we were to provide contraceptives over a very long period of time, such as a year, covering an entire state, we want to validate that consumption will still be much higher, and that this is indeed an intervention that is consistently needed. The second thing that we are working on in our second year of operation is policy advocacy. Of course, it's great that we are able to fundraise and bring money into Nigeria to purchase commodities with and donate them to the public system and meet some of the demand. However, the moment we are no longer able to fundraise, or the moment we are no longer able to operate for any reason, that would stop. So we are also looking for other ways to make to make improvements sustainably. And in talking to experts, we have learned that there are some policy efforts that are favored by the Federal Ministry of Health, such as encouraging state governments to first pass legislation that would allow them to procure their own contraceptives, because currently that is not allowed without an additional piece of legislation in each state. And secondly, supporting states and supporting the family planning unit within the state and other actors within the state who already want this to happen, supporting them to get a budget line allocated for family planning commodities and then released for family planning commodities. And we are very optimistic about being able to get this policy passed. it seems that it is quite universally thought of as a good thing that should happen. That hasn't happened yet just because there hasn't been enough momentum and because there haven't been enough people who have pushed specifically for this. And we are quite hopeful that we will also be able to get some of the state government budgets allocated to fill some of the gap, and then also released, then reducing the need for our work in the state by solving some of the problem at least. And the last thing that is very important for us in program design is monitoring and evaluation. In our first year, we have collected all the data that is collected by health workers in public health facilities. We have developed a computer vision model to help us digitize that data in a streamlined way. But we don't think that's enough moving forward. We think that is probably enough to make sure that the commodities are used the way they are supposed to and to keep track of how many patients actually are in the facilities. But we want to test additional monitoring and evaluation improvements, marking the commodities that we donate, increasing our ability to track them, increasing our ability to detect whether some of them are leaked and whether some of them appear on the black market, and also monitoring and ensuring that the service that is provided in facilities is respectful and is accurate and is actually giving the best level of care that these women deserve. I don't know what this level of iteration is going to look like for you, but I think it is very important that at every step of the program to be humble about what previous success means. Just because our pilot showed pretty good results is not convincing for us enough to believe that running the same project at any scale for any duration of time will be just as successful. That is something that we think we need to test. And despite our program running quite well and showing quite high potential for cost effectiveness, we're constantly looking for ways to test further improvements, A/B testing different iterations to our delivery, to our procurement, and to our data collection to try to improve our cost effectiveness even further. Because of this, currently in our second year, we estimate we can save a life for every $6,600. But we expect that at scale, this number will go down to $2,400 per life saved. I think this is all we have time for today, but I'm very happy to take any questions, and I will see you all, or see any of you who are interested at the office hour after this. If you would like to get in touch, I think I just closed the presentation. Well, reach out on SwapCard if you would like to get in touch. Thank you.
Thank you, Miri, for the insightful and practical talk. Okay, so we just go into the Q&A now. So Miri, from your presentation, you mentioned women use IUD less. Did you try to find out why? Do you think lack of knowledge about that can be a reason?
Yeah, so of course that could be a reason. And from our observation, there is no one reason that applies to every woman. But there are also a lot of other concerns, such as in order to insert an IUD, the provider needs a higher level of skill than, for example, for an injectable or an implant. There's also higher risk. If the IUD gets dislocated, then that happens very rarely. But if it does happen, then the woman needs immediate medical attention. And in some areas that is not available, so that would make an IUD less attractive. And there are probably also other reasons, such as, for example, the hassle of having to get it removed. That is not the problem that you have with an injectable or pills. At the end of the day, there are many different reasons why different methods are suitable for some women, but not others. And we do our best to make sure that every woman can access what fits her body and her needs the best.
Thank you for that response. So this is the next question. What systems or processes do you use to track stock deliveries, transfers, and stockouts? Do you have any tools in place for flagging or preventing stockouts?
So we have a couple of tools that we use for tracking how stock moves and where stock is available. We currently do not have the system in place to flag stockouts before they occur, not because we couldn't do that with the data that we have, but just because it hasn't been relevant for our work so far. But moving forward, as we work closer with the Ministry of Health and with the PHC Development Agency, we will actually put some systems in place that will also forecast when stock is likely to run low and plan replenishment.
Okay, thank you. So that's all we have time to take for now. And kindly note, Miri will be holding our officer at O2 immediately after this session. Thank you so much and do enjoy the rest of EAGxNigeria.